If effusion is present in the abdomen or thorax, get a sample of it. Effusion analysis helps to guide further diagnostics or treatment. For abdominal effusion, try to get at least a half cc and as much as 12 cc's. For pleural or pericardial effusion, use a larger needle and try to get it all, or as much as possible, to improve the patient's respiration and circulation. The goals of this part of the DVD are to review patient preparation for a needle aspirate of effusion or a needle biopsy of a mass, to review the equipment needed, to demonstrate methods of ultrasound guidance of the needle, and to review smear technique for preparing a slide of the sample. Look for the effusion in these video clips as we discuss patient preparation. Consider whether the patient needs sedation for a needle aspiration or biopsy. Many large dogs will show little response to a needle stick to aspirate fluid or urine. Very small dogs are more likely to be sensitive to pain. Some animals are already very depressed and may have increased risk for sedation. Liver and spleen do not have pain receptors, so sedation may not be needed for biopsy of those organs in some patients. The kidneys do have pain receptors, so sedation is needed for fine needle biopsy of that organ. Sometimes a pain reliever like Torbugesic can be given prior to the procedure. Sometimes the patient should be sedated with a short-acting anesthetic. You need to decide. In most cases, the patient has already been shaved for the ultrasound. If the patient was not shaved, consider whether shaving is necessary. Do you normally shave a patient and do a surgical scrub prior to a cystocentesis? Probably not, but you should do what you feel is needed. If ultrasound gel was used for the ultrasound, always clean off the gel. Alcohol will be used as a contact agent. For needle aspiration or biopsy, I recommend a 30-inch or 75 centimeter IV extension set, a 22 or 25 gauge 1.5-inch needle, and a 12 cc syringe. I drape the IV extension set over my neck for better control of the needle. When attached to an extension set, the needle is not as likely to move if accidentally dropped. On the other hand, if attached to a syringe, the weight of the syringe can cause the needle to move a lot and may cause internal damage. Look for the effusion in these video clips as we discuss selection of needle size. For a fine needle aspiration, to obtain a small amount of effusion, I recommend a 1.5-inch 22 or 25 gauge needle. For aspirating pleural effusion from a cat or dog, a 20 gauge needle is recommended. With pleural effusion, you want to draw off as much effusion as possible, as quickly as possible, to improve the patient's respiration. For pericardial effusion in a cat, I would probably use a 20 gauge needle, but in a large dog, I recommend as large a needle as possible, probably a 16 to 18 gauge 2-inch IV catheter. Again, with pericardial effusion, you want to draw off as much effusion as possible, as quickly as possible, to improve the patient's respiration and circulation. Syringe size depends on how much effusion you need to remove. Consider a 3, 12, or 60 cc syringe. To remove large amounts of effusion, a 3-way stopcock can be used with the IV extension set. Look for the effusion in these video clips as we discuss risk of bleeding with fine needle biopsies. The owner should be informed there is always a risk of bleeding with biopsies, and the owner must be willing to take the risk. The risk is minimal with a fine needle biopsy. Is a clot profile needed? If you have time to plan for a clot profile, you should do one. If you can do an in-house clot profile, you should do one. In emergency situations, I usually request a hematocrit and platelet count as a minimum. Normal clot profiles and normal complete blood cell counts do not guarantee that the patient will not bleed. Biopsy is needed to help make a diagnosis and guide treatment. The owner should be informed of the risks and make the decision to take the risk. When doing ultrasound, the room lights are usually off or low to see the ultrasound screen better. When doing fine needle aspiration or biopsy, the room light should be on to better see your hands and needle position. The patient should be placed in whatever position gives the operator best access to the biopsy site. The ultrasound screen should be directly in front of the operator, so you do not have to turn your head to one side to see the screen. You must decide which hand you will use to guide the needle. I prefer to use my right hand to guide the needle, so that means I must hold the ultrasound transducer with my left hand. You may need an assistant to help aspirate large amounts of fluid. In this video, the depth is listed as 8.2 centimeters on the lower right side of the ultrasound screen. Since the needle is only 1.5 inches long, or about 3 centimeters, there is no need to set a depth of greater than 4 centimeters. Decrease depth to magnify the image so you will see greater detail. Some transducers have a seam, line, or groove across the center of the transducer to show you where the plane of the ultrasound beam is. In others, the index indicator shows where the ultrasound beam should be. The beam is about as wide as a 22 gauge needle, and the needle must be in the same plane as the ultrasound beam or you will not see it on the ultrasound screen. A common mistake is to place the needle just outside of the ultrasound beam. Another common mistake is to place the tip of the needle inside of the ultrasound beam and then pull the top of the needle towards you or push it away from you. In that case, you will only see the part of the needle that is in the ultrasound beam. This video shows part of the needle that is crossing but not completely within the ultrasound beam. You see the needle come in from the top left, but then the tip disappears. At the end of the video, I adjust the transducer to match the plane of the needle. Initially, needle placement is always close to but not touching the transducer and parallel to it. The fingers should be on the sides of the needles and not between the needle and the transducer. For a 90-degree method, the needle is pushed straight down in this position. For a 45-degree method, the top of the needle is pulled to a 45-degree angle from the transducer, so the tip of the needle will be directly underneath the transducer when introduced into the patient. For the 90-degree method, use the transducer to position the target on the left side of the ultrasound screen because the needle will come almost straight down on the left. For a tissue biopsy, the needle is placed within the tissue to be biopsied and then moved rapidly up and down about 10 times so that the cutting edge of the needle cuts cells from the tissue. Aspiration is not used during the biopsy procedure. 3 or 4 separate biopsies are usually done. In the 45-degree method, the transducer is moved to position the target directly under the transducer. The transducer is at the top of the ultrasound screen in the curved area. The needle will appear at the left side of the screen and will end up in the center of the screen. For a tissue biopsy, the needle is placed within the tissue and then moved rapidly up and down about 10 times so that the cutting edge of the needle cuts cells from the tissue. Aspiration is not used during the biopsy procedure. 3 or 4 separate biopsies are usually done, using a new needle for each biopsy. To aspirate fluid, you simply place the needle in an area with anechoic fluid and aspirate. In this video, I am preparing to do a fine needle biopsy using a jello mold. The syringe and IV extension set are over my neck. I draw 3 to 4 cc's of air into the syringe to force the sample out of the needle after I collect it. I am looking at the ultrasound screen to my right and using the transducer to position my target on the ultrasound screen. Once the target is found, I anchor the transducer hand and begin to position the needle. I look back and forth between the ultrasound screen and the needle to position the needle. Then I introduce the needle and keep my eye on the ultrasound screen to see that my needle is where I want it to be. Then I run the needle up and down about 10 times to collect the biopsy sample. 3 or 4 samples should be collected and a new needle should be used for each sample. If you cannot see the needle on the ultrasound screen after it is introduced, rather than pulling the needle out and trying again, try to move the transducer to match the plane of the needle. If the needle is still in the target, it may not be necessary to start over again. If the needle is not in the correct location, do not just swing the needle to the correct location. The sharp bevel is like a scalpel and could cut tissues and blood vessels, causing unintended damage. If the needle is completely withdrawn, get a new needle before proceeding. This video shows a better way to adjust needle position. If the needle is not in the correct position, partially withdraw the needle and adjust the angle. Then reintroduce the needle. You can do this as many times as needed. Sticking the needle through the skin and muscle is what causes pain to the patient. Try to stick each needle through the skin only once. Adjust the needle position as needed. If the needle is completely withdrawn, you should get a new sterile needle before proceeding. When an infusion sample is aspirated, you should get a hematocrit of the fluid. A hematocrit of 28% or higher suggests a direct bleed. If the FAST exam shows hemorrhage in 1 or 2 of the 4 abdominal locations, intervention is probably not needed immediately. If a moderate to severe amount of hemorrhage is present in 3 or 4 of the 4 abdominal FAST locations, you should consider giving a whole blood transfusion, giving clotting factors, or consider surgical intervention. Prior to fluid aspirate or fine needle biopsy, ultrasound gel should be cleaned off of the skin and alcohol is used as the wetting agent. Otherwise, ultrasound gel is the first thing in the needle and it may plug. Ultrasound gel stains pink or brown with typical cytopathology stains and may obstruct the view of the cytopathologist and confuse results. It is a good idea to use frosted glass slides and write the patient's name, date, and the organ biopsied on the slide. Some people prefer to use plain glass slides and use a Sharpie to label the slides. This video shows a smear technique. First, I show that the slides have been prepared with patient information. This patient is under anesthesia and the ultrasound gel has been cleaned off of the abdomen. Alcohol is used as the wetting agent. The transducer is used to locate the target and center it under the transducer. A 22 gauge needle is placed at a 45-degree angle to the transducer and introduced into the abdomen. The needle is run up and down rapidly to get a biopsy sample. 3 or 4 cc's of air has previously been drawn into the syringe to force the cells out of the needle. Aspiration is not used during the biopsy process because it would draw in additional fluid and white blood cells from the surrounding tissue and confuse cytopathology results. The biopsy sample is placed at one end of the glass slide. Another slide is placed on top of the sample slide. The weight of the glass slide causes the sample to spread. The top glass slide is pulled away from the bottom slide, making a smear. This process is repeated 3 or 4 times to produce 3 or 4 slides from each organ or lesion for cytopathology. Ballottement is used to cause free particles to move in a liquid-filled area. First, I demonstrate a gentle nudge. Ballottement is a violent bouncing or shaking motion, but not enough force to bruise or injure the patient. A gentle nudge looks like this on ultrasound, but ballottement looks more like this. Stones and crystals are present inside of this bladder structure. Ballottement did not cause the crystals to move. The desired result of ballottement is to cause gravity-dependent particles to fly about as seen in a snow globe. The crystals in this bladder are similar to those seen in tomcat bladders. They are often too heavy to move with ballottement. Changing the patient's position usually causes the gravity-dependent particles to change positions. In this video, the stones and particles move when the patient is allowed to stand, and then move again when the patient is returned to dorsal recumbency.